The elbow joint has 1 degree of freedom, which is flexion and extension. The joint capsule is a compound joint, and it holds bones of the humerus, the ulna, and the radius. The two joints are in the space. The elbow joint is described as the humeral ulnar joint. The joint between the radius and the ulna is the proximal radial ulnar joint. There's another radial ulnar joint at the distal end. The proximal radial ulnar joint and distal radial ulnar joint are the two joints. The joint allows flexion and extension. The articular surfaces in that space allow flexion and extension are the ones where the ulna contacts the humerus. The bit making contact is semilunar notch. Where is that? The semilunar notch. You can see it. It's behind of the ulna that goes into the anatomical space or feature, which is the trochlea of the humerus. There we go. The distal end of the humerus are the condyles. The condyle that is the pulley-shaped condyle is the trochlea. Yep, we've seen that. More laterally placed is the capitulum. And the trochlea makes contact with the semilunar notch on the trochlea notch of the ulna. The semilunar notch or trochlea notch goes right in there and makes contact. The radius does not make direct contact with the humerus. However, when you have your arm and forearm in full flexion, when the radius goes and sits in that space, that is the radial fossa. The radial fossa is in here. Okay. When the ulna sits in the coronoid fossa, there is a big depression. Anyway, I think that's it. When you have your arm in as much extension as you can, the ulna is the only one that contacts the humerus. There we go. Yeah. And sits in the olecranon fossa. Anteriorly, there's a depression for the ulna, the coronoid fossa. The coronoid fossa, yeah. Another depression for the radius, which is the radial fossa, which makes contact in complete flexion, but not in extension. The humeral ulnar joint has a single capsule holding two joints. Lining the bones and lining the articular surfaces is hyaline cartilage. There is smooth cartilage that lies in it. There's no menisci in this joint. The trochlea notch fits tightly in the trochlea itself. Also lining the space is a synovial joint. Because of the synovial joint, it has a synovial membrane, and it's loose on the inside, and part of the membrane slips down inferiorly. Because it slips down, it means that the anterior-posterior aspect of the articular capsule is lax, because that allows flexion and extension. Extension of the synovial membrane is called the stachyform recess, and this goes inferiorly. And I don't know which part that is. Like most of the joints of the body, it has a nerve and blood supply. That is where the brachial artery, which is in the cubital fossa, then splits into branches into the radial and ulnar artery. The branches of those radial and ulnar arteries provide blood supply for that region. Nerve supply from nerves is also in that region. The musculocutaneous nerve doesn't do a muscular job anymore because it becomes cutaneous and sends an articular branch that then goes to the joint. The radial nerve comes from the posterior to the anterior side. The ulnar nerve also travels right by the medial epicondyle. When you have a joint that allows flexion and extension, the support joints you don't really need posterior and anterior support joints. You usually need medial and lateral. There are tracks in which the joints move in the sagittal plane. The tracts are meant to be strong and supportive. The collateral ligaments on the medial and lateral side provide support. In the case of the humeral ulnar joint, in the elbow joint, the medial collateral ligament is more important than the lateral one. The medial collateral ligament, also known as the ulnar collateral ligament, starts from the medial epicondyle and proceeds from there, fans out and diverges and sends bands to the coronoid process. The olecranon process of the ulnar, at the olecranon process of the ulnar, there is a band that meets up with the olecranon and coronoid process as well. The anterior collateral ligament goes from the medial epicondyle to the coronoid process of the ulnar. The posterior band from the medial epicondyle to the coronoid process. The oblique band meets up with the coronoid and olecranon process. The oblique band. Where's the oblique band? From the trivediated band, the strong support on the medial ulnar side of the elbow joint. There is also support on the lateral and radial side of the side called the radial collateral ligament. The radial lateral side, yeah, that makes sense. The radial collateral ligament starts from the lateral epicondyle. Both of them start from the epicondyle. So radial collateral ligament, rather than bending with the bone of the radius, it goes and blends the ring ligament, namely the annular ligament. That is important because the annular ligament provides a ring which the radius does pivoting motion. This is the action of the radial proximal radial ulnar joint. The radial collateral ligament does not to restrict the pronation and supination action. It doesn't insert onto the bone directly, it inserts on the annular ligament. It does provide support onto the lateral side, but also allows the action to take place. The articular capsule is fairly lax, both anteriorly and posteriorly, allowing flexion and extension. There is no meniscus. When you do action of flexion and extension, bones meet in a fossa tightly, the coronoid and radial and olecranon fossas. When you do complete flexion, fat pads in those spaces stop excessive friction, helping to thread synovial fluid in that space. In that space, subcutaneous, there is a bursa for the olecranon, stopping excessive friction in that region too, because the elbow joint undergoes a fair bit of friction and a fair bit of contact with the outer surface. There is a bursa stopping excessive friction, allowing smooth movement to take place. Between the humerus and ulna, it's important to understand that the trochlea is the medial end of the trochlea projects more distally than the lateral end. Medial epicondyle. The medial epicondyle has a large projection. The medial end of the next screen. So here we go. The trochlea, the medial end of the trochlea projects more distally. Is this the trochlea? Projects more distally than the lateral end. I think that's irrelevant actually. Medial epicondyle has a larger projection. The medial end of the trochlea also has a fairly strong projection. As a result, you have the end, the condyle. The condyles being obliquely orientated. When you have flexion taking place. The ulna doesn't go directly sitting on the humerus, but goes slightly more medially. When you have extension taking place in the ulna, it essentially goes laterally. When you do flexion, it allows you to bring your hand closer to your mouth. Extension, the forearm moves laterally relatively to the arm. This is to do with the anatomical feature of the trochlea. It causes a carrying angle. The lateral deviation of the forearm relative to the arm. Important to understand is the lateral deviation and medial deviation. The valgus deviation. The distal structure deviates laterally relatively to the longitudinal axis of the proximal structure. It is called the valgus deviation. This is described as the movement of the distal segments relative to the proximal segment. The forearm, between the humerus and the ulna, there is the trochlea, which is the medial end of the trochlea. The medial end of the trochlea projects more distally than the lateral end. The medial epicondyle has a larger projection. The medial end of the trochlea also has a fairly strong projection. As a result, you have the end, which are the condyles that are obliquely oriented. When you have flexion taking place, the ulna doesn't go directly sitting on the humerus, but goes slightly more medially. When you have extension taking place, the ulna essentially goes laterally. When you do flexion, it allows you to bring your hand closer to your mouth. Extension is when the forearm moves laterally relative to the arm. This is to do with the anatomical feature of the trochlea, which causes a carrying angle. Lateral deviation of the forearm relative to the arm. It is important to understand lateral and medial deviation. Valgus deviation. The distal structure deviates lateral relative to the longitudinal axis of the proximal structure. It is called valgus deviation. When the forearm is deviating out of the lateral side relative to the arm, that is valgus deviation. If it deviates on the medial side, that is varus deviation. It is described as a movement of distal segments relative to the proximal side. The forearm complete extension, forearm deviates on the lateral side, causing valgus deviation. This is the typical posture of the region. What needs to be strong enough to stop excess valgus deviation is a strong tritiated band on the ulnar side. Why are the medial side of the collateral ligaments stronger? Why are the medial side of collateral ligaments stronger than the lateral side? This is to stop excess lateral deviation. We don't have medial deviation as much. We support the radial collateral ligament. The support of the radial collateral ligament is not as strong as that on the medial side. The position of maximal stability in that elbow is when you are in a semi-prone position and 90 degrees of flexion. The position of maximal stability when the bones are making most contact, and that is the position where the interosseous membrane is strongest because there's greatest stability there. The midway between pronation and supination, which is also the midway between pronation and supination. Extension is limited by the oblique angle of the trochlea. Extension is when the olecranon fossa sits tightly in the olecranon process sits tightly in the olecranon fossa, so that you can't do hyperextension in that region. In the olecranon fossa, you'll find a depression that is called the interpicondylar foramen, allowing the ulna to fit there and hyperextend. This is an anomaly that is non-functional. The forearm allows that to happen. Because of extension, we have a carrying angle. The elbow and the forearm is in the position of supination. Notice that when the forearm is deviated relative to the arm, the angle that is formed between the arm and the forearm is the carrying angle. This ends up being slightly greater in females compared to males. The suggestion is that it allows free movement in that same line for females. To do with the fact that females have wider hips than males, a wider carrying angle allows better clearance when you do flexion and extension. Non-functional or statistical differences between male and females are the carrying angle. Females have a higher carrying angle. Functionally and statistically, it doesn't matter. Adults have a wider carrying angle than children. Females have a wider carrying angle than males. Flexion muscles at the elbow joint. Muscles that work at the elbow joint are the ones that are going past from the arm past the elbow joint to the forearm. The biceps and brachialis do this. Muscles like the brachioradialis that help with flexion as well. The brachialis is important for flexion, but the biceps not just help with flexion, but are most effective in flexion when it's also doing the act of supination. Extensors are the triceps. Importantly, they go past the joint. It helps in extension. The small muscle assisting triceps is anconeus. It starts from the lateral epicondyle and goes and inserts on the olecranon process of the elbow. Let's see if we can see this. So up here is a biceps brachialis. That should be the biceps brachialis. I'll just check. Oh yeah, biceps has two heads. So 10 of the short head, 10 of the long head. And then here is the brachialis. So it goes from the mid of the humerus, mid shaft of the humerus, to the ulna. So you see the biceps actually doesn't attach to the humerus at all. It's only from the scapula and the, Just got to check if it's the acromion process of the scapula or... The short head of the biceps brachii originates at the top of the scapula at the coracoid process. The long head originates just above the shoulder head at the supraglenoid tubercle. Okay, so this is the coracoid process, and that is the short head of the biceps. That starts here. So then this is the supracondylar tubercle of the glenoid process. So that is where the biceps of the long head starts. And then both heads join at the elbow joint. Okay, so the aconius is on the back of the arm, but you can't see it in this photo. I think it's this. Is that biceps brachii there? You can see that there. I wonder if I can zoom in. Zoom in. So brachioradialis, these are, that is, this is a flexor carpi radialis, the pronator teres, we know that, the palmaris longus, underneath we have the flexor digitorum superficialis, the flexor carpi ulnaris, and then so the brachioradialis seems to go also in the... okay, so here's the medial epicondyle. So this is where the flexor muscles start. And the extensor muscles are also on the anterior part of the forearm, it seems. So there's an extensor muscle called the brachioradialis, which is there. Okay. The this is another picture. Okay, yeah, long head, medial head, lower epicondyle, irrelevant. Okay, radial ulnar joints. In that same joint capsule, the joint is between the radius and the ulna. The radial ulnar joints the radial ulnar joints, there are two joints, but there's the proximal and the distal joint. So this is the proximal joint between here, and this would be the distal joint. At the proximal end, there's one between the radial notch and the ulna. Sorry, the radial notch and the ulna. Radial notch on the ulna. And the distal end is between the ulnar notch that is lying on the radius. Two notches which then allow movement between the radius and ulna to take place. The radial ulnar joints are proximally and distally placed, and then they allow pronation and supination. Pronation and supination are linked in the sense that both proximal and distal radial ulnar joints work together to do the pronation and supination action. The interosseous membrane transmits the forces from the distal end to the proximal end of the radius. You can dissect to see the interosseous membrane. Fibers of the interosseous membrane are obliquely orientated. Forces are transmitted from the distal end. Forces transmitted from the hand of the scapula to the radius. From the radius, they are transmittable proximally. Forces transmitted to the radius then need to be shared by the ulna. Those forces transmitted on the radius are transmitted there to the ulna, so that the ulna assists in the radius in taking those forces. This allows transference of the forces in the interosseous membrane. 80% of the compression forces are transmitted through the radius. At the proximal end, 20% are transmitted through the radius, because most of the force is transmitted to the ulna. When you have a fracture of the radius, a fracture of the ulna is very typical. So you may have a fracture at one end that leads to the dislocation at the other end. The fracture at the distal end, yeah. Okay, the proximal radio-ulnar joint. This is between the head of the radius. It is a rounded surface. The radial head fits in the notch on the radial notch of the ulna. The synovial joint in the capsule. In the elbow joint capsule, synovial membrane is lying in the capsule. The membrane extends inferiorly to form a sacciform recess, and that creates laxity so that pronation and supination takes place smoothly. The same nerves innervating humeral ulnar joints are important at proximal radial ulnar joints. The median, muscutaneous, and radial. At the blood supply is the branches of the deep and radial arteries. The brachial artery splits into the ulnar and radial artery. The radial goes laterally, providing blood supply for the laterally placed joint. The ligaments of the proximal radio-ulnar joint. So there's the annular ligament that sits around the head of the radius. There you can see it here. It provides a ring, a tight head around the neck of the radius, which is loose as it merges with the anterior and posterior fibers of the elbow joint. Extension of the annular ligament goes from the annular ligament to the next set of radius. The quadrate ligament is the extra support for the pronation and supination. It is the additional ligament in the space assisting the joint. What is this? The bicipital aponeurosis and the biceps tendon. What are we looking at? Bicipital aponeurosis. I'm not sure. Okay, the distal radial-ulnar joint. The distal end of the joint. At the distal end of the joint, there is an interosseous membrane between the two. The head of the between the two, which is the head of the ulna and the distal end of the radius. So there's the distal end of the radius and the head of the ulna. The head of the ulna and the head of the radius are both shaped roundly. The ulna at the distal end has a styloid process. The head of the ulna fits into the notch of the radius at the distal end. And it is a pivotal joint. There is no annular ligament, just a proximal end for pronation and supination. In the space is a fibrocartilaginous disc, which is a triangular ligament. It has an apex at the styloid process of the ulna and sits along the articular surface between the proximal row of carpal bones and the distal articular surface of the ulna. It extends to go between the ulna and the radius at the distal end, between the notches of the radius and ulnar head. It starts and goes into that space. The triangular ligament allows force pronation and supination to take the force out. Again, the pivotal joint has a synovial membrane which extends more superiorly and forms another sacciform recess. The nerve supply is the median nerve on the anterior side and the posterior side of the radial nerve. The median nerve and radial nerve give fibers. I don't think that made sense. The median nerve is on the anterior side, and on the posterior side is the radial nerve. That makes sense. On the anterior side is the median nerve because the median nerve supplies half of both. So the first two lumbricals, which are in the index finger and the ruder finger, and then the Conan's pollicis, adductor pollicis, and flexor pollicis, and that is the medial nerve. And then the posterior side is the radial nerve, which supplies basically the back of the hand except for the fingertips and nail beds or something, because that is the median nerve. So the median and radial nerve gives fibers hugging the interosseous membrane. They are interosseous, the median, radial nerve, interosseous nerves. The blood supply is the anterior and posterior interosseous arteries. Arteries are both radial and ulnar. They give branches, and the interosseous membrane hugs the interosseous membrane. I don't understand that. Okay. The movements of the radial ulnar joint. Oh, we missed this part. So I wonder if you can see this. It was just basically what I said before. The articular disc, which is a triangular ligament. So it is the triangular ligament articular disc is in here. Sacciform recess. What was it about the sacciform recess? There's a synovial membrane and it forms a sacciform recess. Okay, movements at the radial ulnar joints. Pronation and supination along with flexion and extension. So you can have pronation and supination working with flexion and extension. The mid-prone position is the most stable, so I assume this is the mid-prone position, because look at that. Anyway, that is when the anterior, as opposed to like standing with your hand curved towards you. The flexion at the elbow and pronation, or part pronation or supination. So the action of pronation and supination start from the proximal end at the proximal, radial, ulnar, and distal. The pronation of the ulnar is stable. And the radius moves relative to the fixed ulnar. Okay. The muscles that move radio-ulnar joints. So the pronator teres, here's the pronator teres, starts at the common flexor origin, which is the medial epicondyle. Its head at the ulna, and goes across and inserts onto the radius. The pronator quadratus does the action of pronation and supination at the proximal end and proceeds to the distal end. The pronator quadratus allows quick pronation and supination to take place. The muscles with an origin in oblique pathway will assist in pronation. Flexor carpi radialis, palmaris longus, and the muscle in the anterior apartment that goes obliquely across, which is the brachioradialis, can assist. And assist. So there are muscles in the flexor, and one in the extensor can be synergist. So this is an extensor muscle, the brachioradialis. Supination. Supinated muscles from the lateral epicondyle of the humerus, which originate on the ulna. So where's that? Lateral supinator. The supinator is the ulna. That is the ulna. So that's the radius. It must be wrong. Inserts on the radius. From the neck of the radius, the proximal shaft of the radius. The supinator sits close to the radius of the joint, and it's a prime mover in supination. Assisting supination is the biceps. We all know that. And the extensor pollicis longus, which I think you can see in this photo, and the extensor carpi radialis longus. Then, no, you can't say that either. They assist in the pathway because it's oblique on the lateral side. So you can see pronator teres and, oh no, they're not here, you can't see that, sorry. Dislocation at the proximal radial ulnar joint. This is common in young children because the annular ligament in young children is lax. The head of the radius in the space is loose, an action where it is pronated and extended. Children can be skipping and picked up, and you can pull the radius head out of the annular ligament and it will move superiorly. This will cause a bump on the lateral side. There's reduction of dislocation and supinating the forearm, pushing the radial head, pushing proximal will put the joint back in flexion. But don't do that yourself. Okay, clinical considerations at the humeral ulnar and radial ulnar joints. Bursitis is a result of repetitive strain at the elbow, which is a cause of the inflammation of the synovial membrane in the bursa. Epicondylitis is due to strains at medial and lateral epicondyles. The muscle takes origin here. Depending on the muscle overworking, you can get lateral or medial epicondylitis. Lateral epicondylitis is like due to tennis elbow or something. Extensor elbows, muscles as well. Golf is medial epicondylitis. Okay, avulsion fractures. The medial epicondyle, if that's avulsed, the ulnar nerve can be compressed. Fractures, if you fall on a flexed elbow, the fracture of the left and process of the ulna, forward displacement of the distal end of the humerus can pick away a chunk of the coracoid process of the ulna as well, which I think is that. The distal end has a styloid process of the ulna, which can be avulsed too. So I think, no, that's not it. You can't see that. The fractures in this region. Okay, anterior displacement of the distal end of the humerus. The median nerve can be affected, and the brachial artery can split at that point. So the blood flow past that point is compromised, and you can have Walkman's ischemic contracture. The fracture of the supracondylar ridge of the humerus. The supracondylar ridge on both sides make phalanges on the medial and lateral. I don't know what it says. The brachial artery splits into branches that are broken off, and there can be ischemia at the distal end. Finish there. Thanks for listening to this lecture. I know the end didn't make sense, but hopefully you got something out of it, and hopefully you weren't too confused. Alright, thanks so much.